Welcome to our PACE College of Health Professions Dean's Roundtable. I wanted to let everyone know that this program is being recorded for future use. It is great to see all of you here, and I am very pleased to be introducing our speaker, Dr. David Reich. Dr. Reich is currently president of the Mount Sinai Hospital and Mount Sinai Queens. Dr. Reich is also the Horace W. Goldsmith Professor of Anesthesiology, Professor of Artificial Intelligence, and Professor of Pathology, and has been president of the Mount Sinai Hospital and Mount Sinai Queens, both part of Mount Sinai Health System, since 2013. Dr. Reich was chair of the Department of Anesthesiology from 2004 to 2014 and served as president of the medical board in 11-12. Prior to his anesthesiology training, Dr. Reich completed 2 years of residency in general surgery at Harbor UCLA Medical Center in Torrance, California. He received his BS degree with highest distinction from Pennsylvania State University and his medical degree from Jefferson Medical College of Thomas Jefferson University in Philadelphia. After arriving at Mount Sinai in 1984, Dr. Reich completed a residency in anesthesiology and a fellowship in cardiothoracic anesthesia. His honors include the 2011 Physician of the Year from Mount Sinai Nursing, the Mount Sinai Alumni Association Jacobi Medallion in 2014, the 2021 Heart of Gold Award from the New York Heart Association, the 2021 August Heckscher Founder Award for Community Service from Civitas, the 2021 Empire Whole Health Heroes Award from Empire Blue Cross Blue Shield and Crane's New York Business, and Pace University's own 2022 Changemakers in Healthcare Award. Dr. Reich's interests include neurocognitive outcome following cardiac surgery, medical informatics, and hemodynamic monitoring. An academic cardiac anesthesiologist, he has published more than 200 editorials, articles, and book chapters. As a hospital executive, he has enhanced safety and quality by forming an Institute for Critical Care Medicine, rapidly deploying digital innovation tools, including AI-enhanced clinical decision support, and leading in COVID-19 care and diagnostics. Dr. Reich, welcome to our Roundtable series. We are so very pleased and honored to have you with us at this time. I would like to turn it over to you to share a bit about your education and career, as well as what led you to your position today at Mount Sinai. Thank you.
Hello, everyone. Thanks for having me, and really have enjoyed this this growing relationship with PACE, and it has been a great partner of Mount Sinai over the years. Many of the PACE graduates take employment in our health system, and I look forward to continuing to work with your leadership and with the students in helping to grow that relationship. So about me, I'm originally from Philadelphia, and after I did this super rapid medical school thing, it was a 5-year program between Penn State and Jefferson. So I actually graduated from medical school at 22, and being a young person who was gay before it was considered cool to be gay, I wanted to get really far away from Philadelphia so I could sort of live my life. So I was in LA for 2 years. But then I decided New York was better, and that's where I came to start my residency in anesthesiology, and I just never left. The growth route that I chose was an academic one, because within academic departments in medical school type programs, if you wrote papers and it was interesting to write papers, it was interesting to do research, you would climb. And by climbing, I mean the academic ladder. So you begin as an assistant professor, then associate professor, and then full professor. And so by writing a lot of papers, frankly, I was a full professor by 1999. And then about 5 years later, I became chair of the department. So the concept of the academic portfolio was very important for me in medicine, and a lot of my colleagues who are graduating from medical school talk to me about future careers. They often ask me about routes that they could take, and a lot of them say, "Should I get an MBA? Should I do some business training?" And in my case, I didn't really need to take an MBA, at least in my opinion, because I, as a chair of a department for 10 years, you develop a lot of those skills. You learn about budgeting, you learn about managing people, you deal with a lot of HR and legal issues. And you're responsible for meeting your budget every month and presenting the budget every year. So a lot of the business education was very much on the job training for me. I never expected to be asked to be hospital president. I always thought that I would be asked to run a multi-specialty physician practice because as a departmental chair, this was a competency that I developed. And the most important thing that I learned when I became the hospital president at, it was a very big hospital, over 1,000 beds. We have a second campus in Queens. This is before we became a health system, and I still have those 2 campuses. And so it's kind of scary to jump into a new role like that when you jump into a leadership role. And all of a sudden I went from having a $60 million budget to a $2 billion budget, and it's obviously gone up since then. But the scary part was, what did I know about running a hospital? I knew how to run a department very well, but I realized very early on in the process that the vice presidents who were left over from the previous leader needed me to succeed because I knew them all. I'd worked with them for years. And if they weren't successful, then, or if I weren't successful, I should say, then a new leader would have to be brought in probably from the outside. And, that generally means a lot of transition and, some of them would have lost their jobs. So it took me a while to realize that. But once I realized that they were invested in my success and invested in sort of training me on the job, it was yet another situation where I realized that just as we all know in healthcare, it's about lifelong learning. We're constantly learning new skills. So one of the other things didn't quite make it onto the bio that Dean Tye read to us. The great thing about becoming hospital president was starting new programs. You heard on the list about the Institute for Critical Care Medicine. That wasn't easy. Every department had their own ICU, and the chair and the faculty were used to running their own show. And you might say, well, why would you put them all together? Well, the fact is we were never able to have a true rapid response team in the hospital, which goes out usually from the ICU and takes care of people who become ill in the non-ICU beds. We never had, before we created an Institute for Critical Care Medicine, a line placement service so that inexperienced residents weren't stabbing, blindly in the middle of the night. We had trained teams that use ultrasound and achieve much higher success rates and much better patient experience. There are other things as well, but the point is creating these economies of scale by bringing things together, and programmatic development creates new opportunities. And I find that to be very rewarding, despite the pushback from all those people who didn't embrace change. And even still to this day, there's some issues here and there. But after 5 years to 10 years of a new entity, people kind of get used to it. The transgender program was something I enjoyed starting. It wasn't on your list there, but our CEO came to me in 2015 after a very poignant presentation, hearing about the very sorry state of healthcare for transgender people in New York, where we're not talking about other parts of the nation where they're often political opposition to gender affirming care. Here we had an environment that was supportive, but there were no practitioners. So I brought in a surgeon from California who became our preceptor. We became very good friends, and we built a program from scratch, and we're now the largest transgender surgical program in the nation. And that we didn't do our first case until 2016. So building programs, every single one that I build is a lot of work, but often I can, after they're established entities, I can hand them off to other people and move on to other projects. And that has been one of the joys of my professional life is that sort of programmatic development. So I figure I'll stop right there and move more into discussions. I spent a lot of time. One of the things I transitioned to in 2013 was suddenly having 3,000 nurses report to me, which was a learning experience. I had to really, study it in various ways, and I had great education from the chief nursing officers that I've had the honor to work with. And we've learned a lot over the years about what's important in nursing, and also just how nursing is reinventing itself in many ways, because What starts out as an RN may turn into a nurse practitioner or a CRNA, a certified registered nurse anesthetist. And there are people who take their nursing degree and go out and get additional education and become hospital administrators. There are people that go out and start businesses. It is one of the most flexible degrees in the world. And I applaud anyone who gets one and makes good use of it. So I'm hoping I can help provide some perspective on what I've seen, also from the standpoint of the career opportunities for someone who is a nursing graduate. I only blabbed for 10 minutes. Thank you.
Thank you very much for sharing that with us. We have a whole class of nursing students who are having some technical issues with their cameras, so they've been able to hear you, but you won't be able to see the 20 students, but hopefully they'll be able to either put in the chat or raise hand from our ed media tech person who's working on the technical issue with the camera so that they can ask questions as well. Molly, would you kindly moderate for the questions? Thank you so much.
Sure. So if anyone has any questions they'd like to ask Dr. Rich, you can either put them in the chat and I can read them out for you, or if you feel comfortable, please unmute and ask away. You can also raise your hand and I can call on you, whatever anyone's comfortable with.
We have Elaine and Esma and Patricia.
Dr. Reich,
Elaine,
thank you so much.
Hi.
Yes, hi, it is Elaine. Yes.
Yeah.
So nice to see you. So before we get down talking about nurses, I wanted to say, you know, that I'm a speech language pathologist and represent also the other allied health professions that we have here at Pace University, and that I know you have at your facilities. And we've been somewhat fortunate to have some students of ours placed there in the past, and we're looking to do that more often. But I'm curious as to if you could speak a little bit about your relationship or your philosophy as it relates to the allied health professions and the rehabilitation folks that you work with.
Well, I'm very, very pleased to have a really remarkable Department of Rehabilitation Medicine at Mount Sinai. We actually are going to be moving it from the Mount Sinai Hospital campus, where the space is kind of old and tired, to a new renovated space that will be in our Morningside campus in Morningside Heights. And so the key thing about rehabilitation is that when you do it well, everyone who goes through that as a patient absolutely loves the experience, because the teamwork and the mission, or I should say the devotion to the mission that you see in all of the, not just the allied health, but the nurses and also the residents and the attending physicians. And it's a really remarkable thing in rehab. When it comes together and works well, it works beautifully. And I've got to say, our speech language pathologists are some of my favorite employees, because they are so good at getting out there when they're doing their work outside of the department, doing, let's say, a swallow study for safety. They constantly nominate other employees for employee appreciation awards. We have a system here where you can do that. So I think there's something very special about speech language pathology. But just generally in terms of allied health professions, what I have to say is that the administrator that I worked with, still works in the Department of Anesthesiology, but she was my close partner from 2004 to 2014, was a former respiratory therapist. I work with a fair number of people who start with their clinical background in an allied health profession, and then that morphs into an administrative role. So I'd say that the key thing also is that with whatever your clinical background, you bring something special, and that clinical experience and that knowledge and that patient focus, for me, is very important when I have someone who works with me, because I need them to put the patient first. And sometimes if people come from a purely, business management, financial standpoint, they don't always think about things the same way. And that part of the reason I'll be in the OR tomorrow morning. I try to go to the OR I try to go every Friday, but it works out to, with other things happening, around 3 times a month. I get so much positive energy about maintaining my clinical involvement. So the other thing I'd say is that even if you do go an administrative route, if you can, try to keep your hand in the clinical, because it's very rewarding. It reminds us why we went into healthcare in the first place, and it provides strength. And it also, if you're in the clinical practice and you see, there are a lot of things that need to be improved in the way we provide healthcare in the US, and you wouldn't believe it perhaps unless you saw it for yourself. And so I think you have to keep seeing it for yourself to really understand. So I hope that was helpful, Elaine.
Yes, very much so. Thank you.
Very good. Patricia?
I think Esma was before.
Oh, Esma first. All right.
I don't mean to interrupt, but I know Esma's hand went up when I did, and I don't want to. Sorry, Pat.
Okay. Well, actually, as we go from left to right on the screen, pardon me. I'm getting a B minus in Zoom. Okay.
Yeah, it's very hard to keep track.
So, go ahead, Patty. It's all right. Go ahead.
No, you sure?
Yeah.
Go for
Okay.
it.
Good afternoon, Dr. Reich, Rich. Nice to see you today. I'm the director of the simulation lab at PACE on both campuses for all of the nursing and allied health programs. So a lot of stuff going. I've been doing it for 20 years. It's an amazing field that has changed so much. The first training class that I took on one of the mannequins, I was in a room full of anesthesiologists, because that's the only people who were using it at the time. And I thought, oh my God, how did I choose this? Because I couldn't keep up with the medicine of anesthesiologists, because I am not one, but I learned a lot from them, and they were early adopters. But my question is, with all the new legislation about the substitution of clinical training hours with simulation, and the trend that has to try to take the burden off of the hospitals for clinical placements, what is your thoughts on how that's going to pan out with the substitution, and the pros and what you see as the pros and cons of substitution?
Okay. Well, first of all, one of the things that we talk about a lot in the last few months, because of the sort of post-COVID staffing shortages, which, it's nursing, of course, but it's everything. If it's a radiology tech, a lab tech, you just fill in the blank, and it's all very short. That creating pathways towards more effective education, especially at the time when the pandemic was really serious and it was harder to have in-person work. I think we learned a lot about what we can do remotely, and we also learned what remote doesn't do. Simulation and full environment simulation teaches skills that you can't really learn in the clinical environment, because it's about rare and difficult conditions. It's training you to think outside of the box and to get out of your tired old patterns and learn something new, and develop skills in managing crisis situations. So I think simulation, as an anesthesiologist who's been through it several times myself, I've never been through a simulation session where I haven't learned something. And where I haven't, in my view, been enriched in my career. However, we also learned in the pandemic that a lot of classwork and clinicals got substituted with Zoom type education. And our new nursing grads have had a little bit of, in my view, a bit of a setback compared to traditional education, because they haven't had as much in the way of clinicals in the units. And so I think the key point is that there needs to be balance. We saw the balance shifted away from in-person clinicals during the pandemic by necessity. We had to keep people safe. But we also saw that there is probably a limit to what we can accomplish with remote and with simulation-based training. And so probably a complementary approach where we do all three, and we work over the years and establish, based upon maybe some outcomes research and looking at how our graduates do in the profession, I think we can find that balance. And I expect that balance will continue to shift over time. To take someone and turn them into an oncology nurse, a cardiothoracic ICU nurse, someone who works in oncology in the ambulatory setting versus the inpatient, very different skill sets. And a lot of those clinical competencies are taught sort of on the job. And I think that we also are challenged to get to the next level in terms of how the remote and the simulation-based education has to evolve to handle all of the amazing and diverse competencies that we ask our staff to manage.
Interesting. Yeah. I mean, one of the things that I like that you said is effective education. So what makes the simulation effective? We have to look at the outcomes to, some of the Zoom things, we have the avatars, but not the same as treating a patient. But I truly feel that in the sim lab, when we have the patients and all of the equipment, we can make a true hospital environment. So the balance of doing those kinds of things where we can control the content and then having real life clinical, I think the synergy of those two are really going to come together in the next 5 to 10 years and help us be more effective in training the future healthcare providers of the world. So
Very
thank you very
good.
much.
Thanks for being and also an early adopter of simulation. Esma.
Hi there, Dr. Reich. This is Esma Polderick. I am the undergrad chair of nursing. Thank you so much for being so progressive in your relationship with nurses and really truly being hands-on, especially when it comes to going to the floor or the OR. I think it's unique sometimes in the healthcare systems, and you can see why Mount Sinai is, so doing so well and progressive and taking care of its patients. I guess the lofty question that I have, which is probably a tough one to kind of answer, healthcare systems have adopted more of a kind of conglomerate and business type of model. Like, where do you see it in the next, let's say, 10 to 15 years, kind of in terms of the way healthcare systems are going to evolve, like, if at all, kind of, it's a tough one, I know, but I'm just curious.
I'm willing to go there. I think that the I show a slide in one of the talks that I give where I show the bond ratings of standalone academic medical centers versus health systems. This is a slide from about 10 years ago. And it shows very clearly that the economic health of the health systems was dramatically better. And that's sort of proven over the course of time because there really aren't that many standalones. There are situations where we have to, keep, a rural or, a remote hospital, functioning even as a standalone because it serves its community and there's no other option. And it's a very important thing since we don't often talk about the challenges of rural healthcare or healthcare in underserved parts of our nation and the rest of the world. But to go back to your key question, I see the evolution being one towards more remote care and everything from hospital at home to palliative care at home to rehab at home and already remote patient monitoring. By the way, I think the nursing ratios will be the same or even richer in hospital at home than they are in inpatient medicine because think about it, if you were an RN and you had to visit 6 or 7 patients in the day and you have to take an Uber between each one and spend an hour with each patient. I mean, that's a work day by the time you get all that done. So I think the ratio is not going to change, but it bends the cost curve because when you're providing that care effectively for the right patients in the home, or also early discharge from the hospital to the home, like, the last 3 days of colon cancer surgery, just waiting for them to, have the ileus go away. If you do that in the home, you bend the cost curve because you don't need the bricks and mortar, the environmental services, the engineering, the electric, everything. You know what I'm talking about. Yeah. It's very expensive to run inpatient care, and we can then use the beds that remain and frankly turn them over a bit more quickly, but also use them only for the period of time when people have that the highest level of acuity. So I see us evolving in the care delivery model towards a lot of remote and hospital at home and in hospital at home. I don't see it as you're just sitting in a bed in your house with an IV and a nurse shows up once a day to give you some meds and draw some blood. I see it, and a doctor comes in once a day to examine your, listen to your chest and whatever, palpate the belly and then go. It seems to me that it's going to be by necessity very tech driven. For example, right now we use a system sold by the company, I think they're called Avasure or Avasys, and we have remote monitoring where we have one person monitoring, I think it might be 12 or even 16 patients in a command center, and they're watching hospital patients that otherwise would need a one-to-one observation with like a patient care associate. And obviously it's an economically viable model, but think about it. If you're a hospital at home, you had a camera, would you be able to have effectively a 24/7 call bell where the people could talk to someone in a clinical command center and also have AI enhanced analysis, not just of the vital signs and other things that are going on, but of the visual imaging to keep people safer. And so I think that nursing will be staffing not just hospitals and not just hospital at home, but command centers. And I think that's a real opportunity for people to move into the highest tech field. So to answer your question, Esma, I think it's about the tech and the evolution and the fact that we're going to be forced out of the hospital because hospitals are just too darn expensive unless you've just had, heart surgery, neurosurgery, transplant surgery, or very high acuity oncology care.
Thank you. Interesting.
Very good. Ian's next.
Sorry to interrupt. We actually have a
Sure.
few questions that have come up in the chat. I want to make sure that the students that are in the class that's joining in get to ask their question. So the first one that came in is, how are language barriers addressed at your agency? Are there interpreters available to address diverse client populations?
Yeah, it is required that you provide translation services. It's actually CMS, a standard of I think actually condition of participation. And so either you need to have certified translators present, which is a problem because there's a place like New York, you have so many languages. I think Queens is technically the most diverse place on earth in terms of languages. It would be impossible to do it that way. So we've moved to these third-party translators where people we give our residents and our attendings an account. And so they use their own smartphone for the most part and basically do a conversation with a translator. And you just basically bring the translator virtually to the bedside. ASL is a little harder, American Sign Language. You have to have special workstations for that, but it's not that many patients, so you can usually accommodate. But the main point is following the rules and just understanding that the very rough phrases of Spanish that I learned over the years that I'm able to use medically are by no means official. So I'm perfectly happy helping someone get through a placement of an IV or induction of anesthesia, and of course that's how that part is done. But I would not feel comfortable, nor would it be appropriate for me to go through a consent process. So I think that it's also just an understanding of the proper use of those services. Hopefully that was a good answer to the question. Something else, Molly, or should we move on to Ian?
Sure. I'll just do one more and then I'll hand it over to Ian. The next one is, how is your agency working to address nursing retention? How is your agency prepared for challenges associated with the recent nursing strike in New York City?
I think what we've learned is that the COVID era was not good for nursing, but for everyone else too. There's a lot of burnout and a lot of people left the healthcare profession. I think to a certain extent, there was a real realization in 2020 that going into healthcare, you actually could be putting your life on the line because certainly in the beginning phase of COVID, when 800 people were dying in New York City a day, everyone was unified in our effort to do the right thing. But oh my goodness, the level of burnout that was induced by that first wave and the subsequent waves, and the fact that it didn't just start and end and we had a ticker tape party and we were all done with it. It just went on and on and on. So throughout many aspects of healthcare, but especially in nursing, we have seen this level of burnout and dissatisfaction with the profession. So one of the challenges we face is not so much that we don't recruit enough nurses, but that the retention piece is the most difficult. And I think about that, and I've been having a lot of meaningful discussions. I just think it's probably best if we don't talk about labor management issues in great detail. But the key points that I think we learned about nursing retention is that when you are a new nurse and you have come off orientation, because basically union rules that we have in heavily unionized nursing states like New York and other parts of the Northeast, you're pretty much guaranteed to be sent to the night shift as your first job. And the night shift, there's just less support around. There are fewer providers at the advanced practice provider level, at the attending physician level, and nursing education has shifted, and nurse educators, there aren't as many of them anymore. So we're working on a process where we saturate the night shift with more senior clinical nurses and other experienced people. We're working on what we'll do in terms of the contract and shift differentials to make that attractive to those people. But you got to get more senior people who can do that education at the bedside at night, so that we can make those new grads feel supported. We're still going to lose some to the traveler situation, because agency nursing is very lucrative right now. That'll probably balance out over time as shortages gradually ease, but it's a necessary evil right now. The problem is the nurses that are full-time aren't always very happy with the traveler nurses. They feel like they don't quite have the same competencies and pull their weight. So we have to find a way to get the senior people to support the very new graduates, because it's that cadre of people where we have the greatest difficulty of retention, and we have to focus on their experience. It's a bit of a catch-22, because people bitterly complain about having inadequate staffing, but then you have travelers to fill in the gap, but people aren't happy with that. And then, of course, there are call outs, because people regard that often as sort of an entitlement. And so the call outs exacerbate the shortages, which exacerbate the difficulty in being comfortable with the position. And, there are only so many people you can hire in this environment, because they're just not that, it's a nationwide, worldwide, perhaps, shortage. So it's, I think we're still in for some tough times in nursing, and that as we get farther from the pandemic, I expect that it will gradually ease. But in the meantime, I think the key focus has to be on retention efforts, and a lot of that is about support from people who are experienced.
Thank you. Now, Ian, back over to you.
Thank you so much for speaking with us here today. And I apologize if there's some background noise. I'm taking this call from the library. But I was really interesting to hear you talk about setting up the Center for Transgender Health at Mount Sinai, which I think is amazing. And I was interested in hearing a little bit about what it's been like educating the staff at Mount Sinai on the specific kind of needs of transgender population and generally for queer health. And if there's been any kind of roadblocks or challenges in getting that information out to workers at all different levels.
Well, Ian, yes, it has been a challenge. One of the things that, and one of the reasons why I feel that the transgender program has very much enriched my life, is I learned so much about a group of people who are just in a place in society where they face a huge amount of discrimination, sometimes frank hatred, and have an incredibly high level of suicide compared to the general population. And so creating an environment where people feel safe has been very difficult. I constantly heard people, especially in the early days of our program, patients, who would say to me, thanks for establishing a center like this, because every time I went to a healthcare provider, I felt like it was adversarial, that I had to actually tell the person how to treat me, and not just, and what medications I needed, et cetera. And, that they would ask, bizarre and strange questions. So it's all about training and sensitivity. And so this, and I'll say it a little broader than just than the transgender and the gender non-binary program, Ian, it really extends to so many areas of what we do. you can have an ultra-Orthodox religious family that is completely out of their element when they're in the hospital. Culturally, they feel totally disrespected. In many ways, it's the same as a transgender population, because unless you help your staff and you train them in what's important for transgender people, it's very important we train our staff not to misgender, to use the preferred pronouns. And we revised our electronic health record to show the preferred pronouns and also the preferred name. We're stuck in medicine a little bit with legality, so we still have to show the legal name, until such time as that is, officially changed. Leaving that aside for the moment, I think that in general, one of the problems that we have in healthcare is we often assume one size fits all. If I train someone in terms of how to interact with someone who's middle class English speaker, with a college level education, you haven't trained your staff to do anything, because there's so many knowledge deficits out there, and it's up to us to help our staff reach that right level. So I'm sorry I generalized it a bit, Ian, but I think you get the idea that to be ultimately successful, it's about training and cultural competency and creating an environment where people feel safe.
Thank you so much.
Yeah. Elaine, back to you.
Sorry. So many different things going through my head, but one of the things that's important is interprofessional collaboration and interprofessional care, right? We know that outcomes for patients are better when health professionals work collaboratively, right? As a training institution, we're quite committed to interprofessional education. But I wonder if you could share with us, because we're preparing the health professionals of the future, and we work very hard to provide that interprofessional education to them to try and prepare them for what they're going to need in terms of their interprofessional collaborative practice out there. And it's not always the reality. What we teach them in terms of how professions can interact is not always the reality of how professions do interact or can interact. Case in point, time constraints and all that. Not everybody can sit down and have an hour team meeting together, et cetera. But we could use some insights in terms of what would be helpful for our students to learn about interprofessional collaborative care as they become your employees.
Well, I think the essence of it is going back. Who's my simulation expert? Is Patricia? Is it? Yes. I think that at the educational level, when you're training people and getting them into their first whatever months or years of training, and they're starting to develop the content knowledge, that we have to then transition, or at the same time start teaching them about those communication skills that are exactly what you're talking about, creating that interprofessional collegial atmosphere. And so I would say that it's two-phased. Number one is, of course, at the earlier level, a simulator doesn't require an expensive facility and a mannequin. A simulation can be a simulated set of patients where a team is coming together and talking about the management of that patient. So the speech language pathologist may be very much involved in with a dietitian in helping devise what a safe diet is for someone with a swallowing disorder after, let's say, head and neck surgery. Or and at the same time, the social worker is considering what's going to happen with placement for the individual who might need to go to subacute rehab. And the case manager is working hard to figure out what the appropriate length of hospital stay is. And of course, you're going to have some sort of physician or NP leadership as well at the provider level, setting the course of the medical care. And so clinicals also become very important. So the sooner you can embed people, even at the level where really they're just shadowing and not actively contributing, but when they're then in those real environments, it's always a little messier than the classroom because we can control our scenarios. And I think that gradually exposing them to the real life world of interprofessional collaboration, interdisciplinary rounds is something which we should really focus on. Not something that I was ever taught in medical school, was how to go on rounds or deal with nurses. I mean, that was what you learned in your clinical rotations, and you were just sort of thrown into it. So I think you have an option as a forward-thinking and progressive educational organization to build that level of collaboration training into the earlier years of the education.
And we do our best, obviously, to do that. There are challenges along the way. And, real life it's never the same as real life. And, one of the challenges we face is getting our students those opportunities for those real life experiences, because as it's difficult to get those clinical placements, particularly in the New York City area.
Okay. Well, once again, Pace and Mount Sinai have a great relationship, so we can always talk afterwards through your leadership about other opportunities. But I think the key is to find it, even if we have to let them go out to a hospital that's more remote from us in terms of distance. We can create the whatever the support for transportation, et cetera. But the key is to get them into real environments, and I think we all agree on that.
Absolutely. Thank you.
Next, we have Sophie has a question.
Hi, Sophie. Yeah.
Hi, Dr. Reich, and thank you so much for these really insightful remarks. So beside my role overseeing grants and strategic initiatives in the College of Health Professions, I also teach as an adjunct mindfulness-based stress reduction in a variety of mindfulness workshop. And I was curious, you spoke earlier beautifully about the challenges of the burnout post-COVID, if we can say post-COVID. And many medical centers are struggling with this. And I'm curious as to what Mount Sinai is doing in terms of approach, offerings, and what I'm hearing in many medical centers is that there are a lot of things that are being offered, but perhaps the organizational culture, while recognizing the problem of burnout, is not necessarily providing the encouraging the time and the commitment to self-care and taking care of mental health. So I know it's a broad topic, and I'm sorry for the long-winded question, but I'm curious as to your thoughts on how Mount Sinai is approaching this.
Well, first of all, I think I should just say nice things about our HR department, because our chief human resources officer is a former nurse. We actually worked together when I was a resident. She was a junior nurse in the cardiothoracic ICU, and she rose through the ranks to be chief human resources officer. And she has been a champion of providing mindfulness programs, whether that's apps. Pre-COVID, we had a lot of mindfulness sessions in groups, and also focusing on healthy eating. I think the key thing is that we're large organizations, and we have to do a lot of things to support staff. So some people would want, a lounge area. We did a lot of those during COVID, where we call them recharge areas, where that would occur. Long before COVID, we also began a program where our spiritual care department would walk around the hospitals and the ambulatory areas, and in all the different areas where our staff were, they would provide, we called it eventually a take 10. Originally it was called cheat time, but I guess they decided that was too ethnic. So take 10 is, there's, turn the lights down. There are little, fake electric candles. There are kind bars, and there are decaffeinated teas. And I did it a few times. It's really nice. Just to, you have to provide actively ways for people to de-stress, and even doing it for a few minutes. Other people have brought in massage therapists. I think there are many ways you can do it. And I hope the key is that we find that right balance where we do that, but I would also argue that things such as reward and recognition of the staff, recognizing a unit that's excelled in a particular area, it also creates that good atmosphere. I think it helps fight the burnout when people see their successes and when they jointly celebrate. And when I do those things, we usually bring along balloons and certificates and a trophy and cookies. Now, there's only one nurse who was in the cardiac area who argued that we should be bringing crudité because it was healthier, but we'll let that one go. Very good. So Dr. Dean Tye next.
Hi. So as a leader in academic medicine in multiple fields and a high-level administrator, you may have the chance to interact with global as well as national and state leaders. From other countries, are there certain aspects of healthcare organization at a governmental or societal level, or in policy or law or culture, that you think might be possible for the US to incorporate within our economic and political realities?
Well, I think if I can read between the lines with your question, Dean Tye, we're both advocates for universal health care. So will we see that in the US in the foreseeable future? I'm not so sure, but we did make some progress in the US with the Affordable Care Act, also known as Obamacare, in extending healthcare coverage to a much larger portion of the population. And probably, the healthcare coverage actually peaked during COVID because of further expansion of Medicaid. It's probably going to back off a little bit now. So I think that to the extent that we can all be advocates for doing the right thing, which is universal healthcare, and working towards the things that'll work in the US, eventually, such as things like, not Medicare for all, then Medicare for more, and gradually increasing the amount of coverage, we will help. But the other piece of it that other countries do well, which we do very poorly in the US, are the complementary social services. So unless we have stable housing, unless we have food stability, and some decent level of nutrition, unless we have social services that can address the real problems that people have, they may have access to a healthcare, but it generally means they're just waiting until they're so sick they have no other opportunity and they go into an emergency department, and that's not what we want. So we talk a lot about population health, but there's no economic model to support that. And even though we spend the largest percentage of our GDP on healthcare, it's not all that well spent. And part of the reason for that is we came at it in a very, frankly, inequitable, if that's the right word, way within our nation. And breaking down those inequities is something that we all have to fight for. Some of that will be making sure that Medicaid coverage is actually coverage. Because if it doesn't actually cover the cost of care, it's hard to get providers to provide that care. It's integrating the social services together with that healthcare, and also perhaps moving away from a society where everyone who wants an MRI gets an MRI. If you're in the UK, it's a very different approach. They decide, what happens on the medical side. You might argue it's more paternalistic, but they bend the cost curve in the right way. So I think that the problem with US healthcare is we're not really ready for what it would take to have universal healthcare, because everyone would have to deal with somewhat less in the way of services so that more people could have the services. And in the US, we're not very good at sharing. But I think that if we all stand up for it and demand it over time, we will make incremental progress. Back to Ian.
So before coming to PACE for nursing school, I used to work in data science, and I see that you are a professor of artificial intelligence. So I was interested in hearing about if and how like Mount Sinai is currently incorporating machine learning, artificial intelligence, all of the progress in that area into like patient care or any operations. And I guess maybe just with your insight, like what you see for the future of that whole space.
Yeah, we built a group called Clinical Data Science. I actually started out with a group very much before AI and machine learning was considered anything viable in medicine. I called it our little big data group because we were looking at big data, but the group was kind of little. So we started talking, and the nice thing about working at a medical school is you have a lot of bright people from different areas that were starting to use artificial intelligence, machine learning. And what we discovered that worked best for us in clinical decision support was finding a way to help us bring the right individual to the right patient at the right time. And so, for example, one of our first and most successful modules to date is one that looks carefully at the electronic medical record, and it determines who's at the highest risk of malnutrition. Now you might think, malnutrition, you can figure it out. You got screening tools, look at the person, they're skinny, you know, they must be malnourished. But malnourishment is quite ubiquitous, and you don't have to, you can be obese and very protein calorie malnourished at the same time. So the algorithm helped us triple the likelihood that a dietitian who was sent out to see a patient at Mount Sinai Hospital would actually make a diagnosis of malnutrition, and of course, then prescribe therapy to treat it. And then that helps so many things. Another one, which we showed in a research context and are now bringing into production for all, is a clinical deterioration predictor so that we could bring the rapid response team from the intensive care unit to the patient's bedside to those that are at the highest risk of deterioration. We have a delirium prediction model because we have a delirium management team. We have a falls prediction module because there's so many people at risk of falls in hospitals, and it's more accurate than the traditional screening scales. And so we're able, in my view, to constantly look for and increase the number of applications for this. The one I don't talk about as much in this group, I will, is we also have one that we use in medical oncology. And it helps decide when palliative care consultation should be required. And usually it's, prediction of, likely length of remaining life, depending upon the oncologic diagnosis and all the other information. Our algorithm fires on 70% of patients at their first visit for metastatic lung cancer, which probably doesn't surprise you as clinicians, but think about it and think about what that means if you go into medical oncology or you're in a medical oncology practice about,
all right.
trying to, think about how to effectively provide that, that level of care. And so clinical decision support, which I like to call augmented intelligence, not artificial intelligence, is a tool to help us, to help our clinicians do a better job, to provide more vigilance, because you can't constantly be watching every patient 24/7, but computers don't get tired. So I believe that AI and machine learning, when applied properly, is great. But the caveat is there are a lot of people who have magical thinking. Oh, I have a command center and I'm just going to call an AI company and they'll be able to tell me how many beds I should manage and who should go to which bed. Come on, it's just they're silly things. But being able to risk stratify and taking relatively expensive teams of people and deploying them more effectively, that's good care.
Thank you.
We're almost out of our scheduled time. Were there any more questions, Molly, from the class that they are texting to you separately?
The only other question I got was in relation to support for new nurses within your practice or your agency, but I know that that kind of tied into the discussion about retention as well. So they said thank you for answering their questions. They really appreciate getting to hear from you.
That's great. And, I think I'll just emphasize that again, that one of the keys is getting a junior person to feel welcomed. And that's something which we all have to work on. And by the way, as your students and you become new graduates, advocate for yourselves. Talk about what it will take for you to be retained in that job. Don't be passive about it and say, oh, they're jerks and I hate this place and I'm just going to leave. Speak up. say, oh, if we had, a ratio of 1 to 6 instead of 1 to 7 at night, or a senior clinical nurse, that's what I need because I'm brand new at this stuff. I don't know how to do X, Y, and Z yet, and I need you to teach me. So don't just, perhaps be a little bit more aggressive about it too. That's, it's advocacy and it's professionalism. And I think you can be that. And as a new and energized, generation coming into healthcare in an era of shortages and burnout and all these sorts of things, talk about what it will take to not be burned out.
Thank you very much again, Dr. Rich, for taking the time to speak with our students and sharing your wisdom, and very frank and encouraging views as well. And thank you to all of our students for your great questions and for taking time to come today. I know you're very busy, and I'm always amazed when I get to speak with you individually. So I really want to thank our students for coming and really great questions, and our faculty and staff also for great questions, and our team and development for all of their organizational skills as always. Thank you, Erica, Molly, Joe, and Jody, and Sophie, and all of our team for coordinating this, which when I see the email chain sometimes, and I only see a few, there's an awful lot of work behind the scenes so that we can have this. And thank you again, Dr. Rich. Bye-bye, everybody.
Pleasure. Thanks, everyone.